Hey, welcome back to the Laser Therapy Institute podcast. My name is Dr. Jason Rountree. I'll be your host again today, but I'm joined by a very special guest. We have Dr. Fred Schiffer here with us. He attended Drexel University School of Medicine, where he earned his MD, and that was followed by residencies in internal medicine and psychiatry, as well as a cardiology fellowship. He is a board-certified physician and psychiatrist. He is a research associate at McLean Hospital. He's an assistant professor of psychiatry part-time at Harvard Medical School, and he was a speaker at the 2021 Photobiomodulation Summit. He's also a published author, and he currently sees patients at his office in Newton Highlands, Massachusetts, as well as via telehealth. Dr. Schiffer, welcome to the podcast.
Hi, pleasure to be here.
I'm very excited to have you here. We have some really interesting things to cover today, a couple of neat concepts, a couple of things that are being done with photobiomodulation or light therapy that really is stunning. So first, though, let's kind of start back in the beginning, if you don't mind. Tell me about your interest in medicine. Where did you get started with this whole thing?
Okay, I think you mean my interest in photobiomodulation.
Well, ultimately, yes. I'm very interested to know how you got involved in photobiomodulation.
Or are you interested in how I got into medicine and psychiatry? Or
I would love to hear a little on your initial interest in medicine.
Sure. So in medical school, I had no thought of going into psychiatry. I did an internship in internal medicine and a residency in internal medicine, and then did a fellowship in cardiology at Harvard, and that fellowship was a research fellowship on stress and heart disease, and then to complete my education, I did a residency in psychiatry at McLean. And I was thinking of becoming sort of a psychocardiologist. And what I found was that no one was interested in that the cardiologist gave lip service to stress and stuff. They didn't really want to go deeply into it. And it turned out that it was, there was a lot in that field. I did a rotation at Mass General, and I was working in the ICU, and everybody who came in with a heart attack had a very interesting psychological story. One guy so the cardiologist, he just had a heart attack and came in. But when I spoke to him, his father died when he was 10 years old. And his mother would wring her hands and say, "Oh, what are we going to do? What are we going to do?" And he would say, "Don't worry, I'll take care of it." And he did that all his life. And so the night of the heart attack, he was out to dinner with his business partner, and they had some problems. And the business partner said, "Well, I'm going to take a vacation." And his usual response was, "Well, don't worry, I'll take care of it." But this time he couldn't, and had a heart attack, and he could relate to that, and so there really was a lot to that field, but I wasn't able to promote it, and so I became a standard psychiatrist, and I love psychiatry, but I was always interested in kind of thinking about things and not just learning rote techniques. So at that time, Freud was and Freudian psychiatry was in vogue, and you didn't see a psychopharmacologist. They were kind of weird people on the periphery, so this was 1975. I started my residency at McLean, and it was a 3-year residency. And then I stayed on at McLean as an attending psychiatrist, which essentially meant I had a private practice at McLean, and then I had an outside private practice. And I was noticing that my patients didn't seem to have the ids and egos that we talked about. They're the superego. In other words, when I saw a patient, it wasn't like I understood what the id was and what the ego was, and but it wasn't what I was really seeing was that the patient was in one personality when he was regressed, and then as he got better, he was like a different person, and it was a whole different personality, and that's what really struck me. And I tried to promote that idea about two minds, and it didn't go anywhere. It's very hard to promote a new idea. And then in 1990, I was on vacation with my family in England, in the English countryside, and I was reading a book about the split brain studies. Mm-hmm. And I had studied it in college, but I didn't really understand what it meant. So these studies were done for people with terrible epilepsy, that their lives were completely disrupted by constant seizures. And so there was a drastic treatment which was to cut the connection between the two halves of the brain. So the brain is sort of like a walnut. It has two wrinkled halves, which are the left and right brain. And there's a stem between the two. And the stem is called the corpus callosum. And so the split brain operation was, I'm going to turn off my mail.
Oh, sure.
Okay. So the split brain operations were done by Dr. Joseph Bogan, and there were Dr. Roger Sperry, who won the Nobel Prize for these studies, was at Caltech, and he was the physiologist in the studies, and they went on for about 10 years, so the important finding, there are like a lot of weird stories about a woman is buttoning her dress to put it on and unbuttoning her dress with her other hand, and it was hard to kind of make sense of what this really meant. But as I reread it, what I saw was that each hemisphere of the brain in split brain patients had a mind of its own. That when you cut the corpus callosum, you actually had two intelligent people, and they both understood English and could do commands very easily, and had a sense of humor. The difference was that the left brain could talk. Speech is, as we know, in most people, is in the left hemisphere. So the isolated right hemisphere was mute, but it could talk with hand signals. It could point to Scrabble chips. In one patient, he could spell words, and his left brain speaking said that he wanted to become a draftsman. And pointing to Scrabble chips, he wrote a race car driver. You see different personalities or different intentions, but they're both intelligent. So they both understood this sort of complex question: what do you want to be when you grow up? He was a teenager, so if you showed a picture, the eyes are connected to the brain in an interesting way. And I have a diagram of it if you want to see that.
That'd be great.
Okay. So the way the eyes are connected to the hemisphere. So here's a split brain patient. The connection is cut here. And if you show an image to the left side, it goes through the lens and hits the medial retina and crosses over and stimulates goes first to the back of the brain, but actually stimulates the brain in that the person, the right brain only can see the picture. If you ask the person who can speak in his left brain, he says, I can't see it. And then if you have a box here with 10 items in it, with his left hand, which is controlled by his right brain, he can easily reach into the box and pull out the chess piece. The right arm and right hand is connected to the left brain. And if you put the same box on the other side, the right hand has no idea what to pick because, as the person told you, he didn't see it. And if you put the item over here, the right brain can't see it, and the left brain will say, "Oh, it's a chess piece. It's it looks like a." It looks like, I think it's a queen. It might be a king.
Yeah.
Okay. So what I found that the most important aspect of the split brain studies was that you had an intelligent person in the right brain who could answer questions and actually these are this is Roger Sperry over here. This is Joe Bogan, and this is Iran Zaidel, who actually died a few months ago. And I went out and did a study with Bogan and Zaidel. Sperry had died by that time, and so these are studies that Sperry did, where they put a word on one side of the so both sides could read, and so on one side of the screen, tooth goes only to the right brain, and brush goes only to the left brain, and so the person will say brush because he can speak, and then he can reach over and pick out the tooth. So I did a variation of that. I did the first study, which was a psychological interview of the two hemispheres. And so on each side of the screen are different words. Each hemisphere sees they each see 35 words, and they're pairs. So here it's admired or disrespected, ashamed, admired, attracted, dishonest. I'm trying to have positive and negative words, and then the person would point with his hand to there were 5 pegs, and his response would be none, mild, moderate, quite a bit, or extreme. And we got very consistent responses. And what we found was in one patient, his right hemisphere was happier, and so the positive responses were higher in the right brain than in the left brain, and the negative responses were lower. And this was statistically significant. The other patient had been bullied as a child, and he told me that it didn't bother him. It happened so long ago. But when I asked the questions, his left hand signing for his right brain said that he was extremely upset by the bullies, and I put in a bunch of bully questions that kind of made up, and so we published that. Yeah,
this was with a split brain patient.
Yes,
is that correct? Okay.
Yeah, okay. But it gave me the idea that maybe what I was seeing, where I was seeing two different personalities in my patients rather than an id and an ego, which exists and which I understand. Maybe there was some connection between the split brain studies and so skip over this. So Werner Whitling was a German scientist, and he developed a very complex device to show movies in normal people to one hemisphere or the other. And it was very difficult to follow what his protocol was. He was tracking eye movements and masking a computer screen. And I had to read it several times to understand what he was doing. And then I figured out what he was doing. And he was just showing the movie to the lateral visual field. So he was really doing the same thing that Fmri did, putting the picture to one side. And so I came up with my own version, which I could afford. So
a lot more direct. You just cover that opposite visual field then. Okay.
Right. So and then I had goggles made, and they, I think, sort of hurt me because they looked sort of goofy, but they were very effective and what we found was that if a person looked out one side, and it could be left or right, it varied within people, their personality would be very different. And they would say that I looked very critical on one side, and they didn't like themselves, and they might have drug cravings. And then I'd have them look out the other side, and I looked better, and they liked themselves more, and the cravings went away. And it happened immediately. It was so the first time I tried it, I tried it myself and didn't respond. I did respond about 5 years later in an interesting way. But my first trial with this, I had my first patient that day was a Vietnam vet, and he had severe PTSD, had a Purple Heart, and had 3 or 4 tours of duty, and his face screwed up when I asked him to look out at one side, and I think it was his right visual field, so it'd be his left brain, and he said, that plant behind you looks like the jungle. And I said, really? And I said, look out the other side. And he smiles. He says, no, it's a nice looking plant. And I knew that I had something. And the rest of when I do this with patients all the time now, I get about 55% of people have these really strong responses, and about another 30% will have a positive response, but it might, like their anxiety level might be like a 1 or 2 point difference between sides. This guy would go from like an 8 to a 2.
Wow.
So the hypothesis is, so what I call this is dual brain psychology. And I'm just started a Dual Brain Institute to have seminars to teach clinicians how to do this, because it's tricky in how to learn it and how to put it into your practice, but it's very useful in psychotherapy to have a person who feels really depressed and they don't see any future, and they look out the other side and they feel better, and there's hope.
So one question would be, is it always the left side? Is it always the right side?
No, that's a very important point that I thought, and I wrote some papers on it that I'd like to retract. I never did, and they're well cited. they get cited all the time, and that is, I thought I wrote papers thinking that the right brain was like the unconscious or the negative hemisphere, and that's sort of the popular notion. But what I found is it's about half and half, and that a lot of times PTSD is more in the left brain. But I think it's impossible to know. It's impossible for me to know unless I test somebody which side is more positive. But everybody who responds has the same response. It's that one side feels good, I look good, and the other side I look critical, and their personality changes, their physical appearance changes in people who have intense responses, and they'll often say to me, you know, my chest pain went away. I didn't know they were having chest pain. I've had patients have just generally feel better, and their pain often decreases. It's often, I have some examples, kind of amazing. So I did a study. So this is kind of the theory. So there's a healthy side, and here's a real mean looking guy there. Actually, this is an interesting. Let me before I get. This is maybe I might come back to this if we have time. This is a transcript from a patient who had a strong response, and you see the psychology. But it's not just that he feels good. It involves the problems that he had. I treated him for cocaine addiction. He did well, and I had him come back. And I'll read a little bit of it here. And so I asked him how he feels. I don't know which side he's looking at. And I'm getting away from your question. So I don't know which side in a given patient. And we use that to study RTMS, and I'll show you that. And that's how I got to photobiomodulation. Okay, so it's coming up here. But I'll just read this quickly. I asked him how he feels. Anxious because I can't see what might be coming at me from the other side. Is it a new feeling or a familiar feeling, I'd say? Sort of a familiar, because I'm in business and you never know what's about to happen. Definitely unknown. Now, it's interesting. He doesn't connect it to his psychology. It's just, you know, he feels better. Would you try on the other goggles? So I had two pairs of goggles. How much anxiety are you feeling looking out the left side? So this is his right brain. I think less mild. Can you describe the difference between how you feel on one side versus the other? I'm more relaxed on this side. On the other side, I'm more uptight. Let's put the other pair back on. How do you feel? Same as before, not as comfortable. I'm just thinking about things that I did in the past and everything about me then. I really didn't think about anybody but myself and the abuse, some of those things I've been through in life. It's not what I want to remember. Not good. Can I take them off?
Wow.
So it's really, you know, intense. I just want to ask one more question. Let's say, can you relate these uncomfortable feelings to your father? Now, see, I treated him for 2 years, and so I knew his, you know, that his father was important to his addiction. I don't know. I was never comfortable around my father. With these glasses on, it's sort of like dealing with him again, because it's always the unknown, always a pressure and a problem. Yeah, you feel the unknown, you have the tension. And then he talked about the unknown in business, but it really ties back to the unknown with his father. We didn't know when his father was going to criticize him. So I asked him later on, what would it take him to use drugs? And he says, oh, he was looking at the good side. I would never do that. And I said, well, how about the other side? He said, you know, I think I could see myself doing it on the other side.
Wow.
This is my book here. And Joseph Bogan wrote on the cover, wonderfully readable, well-informed. This is the best book ever on the social and psychiatric implications of the split brain research. And Candace Pert, who discovered the opiate receptor, said Schiffer rivals Freud in his revolutionary theories on understanding the human psyche. Now, I learned later that she was talking about Ludwig Freud, who was Sigmund's brother, who was a baker.
I'm sure not.
This is a second edition, which has a preface that brings up this first came out in 1998 and has a lot of transcripts like the one I read to you. And then there's been a whole bunch of research that we've published at McLean since the book came out. So that's included in the second edition.
When did the second edition come out?
In August of this year.
Brand new. Awesome.
Yeah. Okay. So I took my goggles down to Alvaro Pasqualeone, who at that time was a well-known researcher. He still is. But at that time he was a pioneer in transcranial magnetic stimulation, which is a treatment for depression. And for reasons that aren't clear to me, they always stimulate the left side. And so I predicted that if your left side was your negative side, you wouldn't do well. And if it was your positive side, you would. And so he took the glasses, and then I had trouble getting him to answer my emails or calls. And so finally, I actually had to go to his office. And so over here is data from a paper that we published. And this column here are the people who felt worse in their left brain. So when they look to the right, they have more depression than when they look to the left. That's what that means. And
this is right visual field versus left visual field.
That's right.
Positive. Okay.
Yeah. So down at the bottom it says that. So that it's how depressed are you? So if you're more depressed in the right visual field, well, I know that this is the negative side. This is the left negative. I'm getting confused when I look at the label here, but I'm not going to belabor that. But the people we predicted to do poorly did poorly. In other words, this is the Hamilton Depression Rating Scale, and this is the change 2 weeks after a 2-week treatment. And so most of them have less than a 20% improvement, which is not good. 50% is considered a decent outcome. And all the people who had that, except this one left-handed woman, were predicted to do well. In other words, their left hemisphere was, by this simple goggle test, positive. And they responded very well to the TMS. And I replicated it with a group in Canada. So that these are 2 papers that we published. And we got the same result in Canada. And there was a sexual difference between males and females. Males responded, they were a little more predictable than females. And we got the same gender difference in both sites. And I just want to, I think there's a picture up here. Yeah, here. So this is a Fmri study showing that when people were in the scanner, these were 7 people from our lab, and they looked to the left for 30 seconds, looked to the right for 30 seconds, and then repeat that. And then this is the combined data of 7 people. If you look at one person, you don't see this. But with the combined 7 people, and then we can intensify the image, it shows that, so they're looking to the left here, and it actually activates the right brain. This is by an fMRI, which shows blood flow in the brain, in one hemisphere relative to the other. And then when they just look the other way, it shifts. So that we have fMRI evidence that this is a real phenomenon that's happening, and it's happening in broad areas of the brain. It's not just like one little area. It's not just in the back of the brain, the occipital area.
It's the entire hemisphere almost.
Yeah, it is. And then this is interesting. This is a paper that we have, we're about to submit, that we have a computer test to, instead of using the glasses or hands or an envelope. And what we found was that the nucleus accumbens, the laterality index, which is the left, there are 2 nucleus accumbens. So most people don't think of it that way. There are 2 hippocampus. There's a left and right, and a left and right amygdala. So if you take the left minus the right over the left plus the right, you get what we call laterality index. And what we found was that the hemispheric valence, which is what the test result is. In other words, if you're more depressed on one side than the other, then we'll say your left hemisphere is positive plus 5 or something. And so there's a correlation between the laterality index of the nucleus accumbens that's highly significant with the valence. So if you have a left positive valence, if your left brain is positive, your nucleus accumbens on the left side is larger than if you have if you if your left is positive, your nucleus accumbens is larger on the left side than the right side, and the same with the hippocampus. With the amygdala, it's actually smaller on the left side, and so it's very interesting. So you have the reward center and the fear center in opposite directions. Just with the hemispheric valence that we're measuring, either with the computer. With this, we use the computer test, but you can use either the goggles or an envelope or that. So I couldn't carry a TMS machine up to my office. So I wanted, and I couldn't afford one. And, so I wanted something I could, because I tried to get Alvaro and other, the group at McLean that does a lot of TMS, tried to get them to stimulate, to put the magnet on the right side of the head in people that the simple test showed might benefit them. And it turns out that TMS has a benefit of about 50%. In about half the people benefit from it, and so if they followed this test, it might be possible that they could double their efficacy, and their efficacy is just borderline. It's and people usually have to go back and get retreated, and so it doesn't work in a lot of people. But I couldn't get anybody to put the magnet on the right side. So I gave a cold call to the Wellman Center at MGH. It's the Wellman Center for Photomedicine. and I said I knew a little bit about near infrared light, and had used near infrared spectroscopy in some of my earlier studies, so I knew it went through the skull, and so my first question was, would it be safe to put on the head? And the person I spoke to said, well, if you don't hurt the skin, you're not going to hurt the brain because the power falls off exponentially. And so I got passed around. There were a few people who weren't really that interested. And then there was a guy, and we sort of hit it off. We had a nice connection, and his name was Mike. And I had no idea who he was. And we got talking, and we decided to do a pilot study, and we got great results from it. Mike turned out to be Michael Hamlin, who has written 700 papers on photobiomodulation and written or edited 17 books. And so I ended up with the right person.
You stumbled into the right person for sure. He's done so much for photobiomodulation. Yes.
Yeah. He's really the leader, so I might have the results. So yeah, this is the paper we published in 2009, and there were 10 patients, and a lot of them, none of them were active substance abuse users, but they had histories of substance abuse, and so this was the device that we made. Mike heard about this LED that had just come out, and so this is a computer fan on top and a heat sink, and you can see the heat sink here. This is the LED itself. So it's a homemade device. I had an engineer in Cambridge make the power supply, and these are two near-infrared spectroscopy pads, the Somanetics device, and we really didn't need the goggles, but we didn't know that then. So we have safety goggles on, and then we found that there was a change in blood flow more in men than in women, and then 2 weeks after one treatment, we had a dramatic decrease in the Hamilton score. It went from 29 to 11 2 weeks later, and then it went up at 4 weeks to 17. So it was still about half of what it was initially.
And this is just a unilateral application of light. No, we're not talking bilateral, which I think we've seen a lot of studies that, irradiate both sides of the head or the entire head.
Well, no, this is actually bilateral, although we did some measurements after each side, and there were significant unilateral effects. But we weren't, I didn't want to get into dual brain psychology because it was too weird, and it was hard enough to get IRB approval at MGH. We did this study at MGH, and so we decided to do both sides. But the interesting thing is that although we got these really great results, this is the depression. The anxiety score is actually a little bit better, and nobody said, "Boy, I feel great," or "Wow, can I have another treatment?" In other words, the only way that we knew that there was any effect was we gave them a Hamilton at 2 weeks and a Hamilton at 4 weeks, and the scores showed an improvement. But the patients themselves weren't like the guy with looking at one side or the other with the goggles, and he had this huge change that you could see immediately. So at a meeting at McLean, someone suggested, well, why don't you try it in your practice as an off-label treatment, the unilateral treatment. Mm-hmm. So I did that, and I got from the get-go amazing results. And I have a audio recording I can play for you if you like. Would you like to hear that?
Yes.
A patient being treated. Okay, so here's a guy who had trauma as a child, and he had a lot of operations and had a feeling of hopelessness because they always went bad and they had to be redone, and so he suffered a depression. His depression was better, but he was coming in once a month, and his complaint this time was that he's an amateur songwriter. He has another job, and so he hasn't been able to write. And we felt that it was related to the pessimism that he had as a child. Mm-hmm. And so what we did was I do a lot of weird stuff. I'll use a sham, or sometimes a patient will say to me, "Doc, it's not working." And I go over and I look, I didn't turn the right button on. Uh-huh. And so if you put it over the negative hemisphere, you get an aggravation of their symptoms. So it's not horrible, and they don't go crazy, but they. So in this patient, I put it over his negative hemisphere and then his positive hemisphere, so you can hear the difference.
Just right before you hit play on this one, if I can just try and, because I think we might have. I mean, this is so complex. If I can just try to say back to you kind of what dual brain psychology is before we see these effects. Basically, you have, and this is not for a split brain patient, this is for your average patient.
That's right.
But you have two different personalities, two different people, one in the left, one in the right. And it is varied per person as to which side is more mature versus which side is more childlike, I guess.
That's
which
right.
Side is, and so
more traumatized. So it's not only a child, but it's a traumatized child.
Okay. And so then when you say the positive hemisphere, is that the more traumatized side?
No, that's the more mature, healthier side.
Perfect. Okay. So the negative side is more traumatized. The positive hemisphere is the more mature side.
Right.
Okay.
And if you treat that with TMS, the patients tend to do better.
Okay.
If you treat the immature, traumatized side, you're stimulating it, and so they do worse.
I see. Okay.
But it's not, you're not treating this to make the side healthier. What we're doing is we're stimulating the brain, like with the magnet. So the magnet isn't repairing anything. It's just stimulating a hemisphere.
Yes. Okay, perfect. Thank you for letting me kind of recap.
Good. Okay, so
here, and take your hand off.
it'll get clearer.
Sure.
Hold by the side of the fan. Okay.
So that's the fan on the device. Oh, and I've got a picture of a very angry man that he's looking at. And the picture is symmetrical. It's the same half of the face on both sides. So that if he looks at out of one visual field or the other, it's the same picture.
Angry man. How's he look?
Looks mean.
Let's see how it progresses now. The question is, How do you feel about writing music?
I feel like I don't feel good about it. I feel like it's not worth picking up the pen. I'm really discouraged.
Mhm.
There's a lot of a lot of stuff that I'll write and then immediately I put the pen down because I feel like it's automatically not going to come out worthwhile. It's not automatically.
And does that have any connection with anything?
Definitely. There's definitely a theme, a pattern where it's, you know, the same way my experiences in the hospital uh, where I where I automatically felt or automatically experienced like unexpected unexpected complications, and it just seemed like everything always went bad, and it, it's the same thing. I feel like I'm bringing to this project when I write. It's like almost not even worth trying because it's not going to work out. And you know, that's I feel like that's what I see as a pattern.
As he gets treated, it's a little worse, but it's sort of the way he came in.
I don't think I do very well.
And how does that guy look?
It's angry, which
Is it any different than when we started?
yeah, definitely. I feel like a tension, like a tense, almost like a like a knot in my stomach. You know that bit of
All right, so let's move it over to the other side.
okay.
Usually the effect takes about 2.5 minutes. And it's a
Have it on
4-minute
2.5
treatment.
minutes.
Mhm.
And that was about 2.5 minutes. I didn't want to stay too long on that side.
Yeah. So now you're
But
switching
the
over.
thing is, if you do the positive side after the first after the negative side, the patient's well, and it's as if you never did the negative side. So he's getting treated here. Let me see if I can speed it up.
It's not in the chest.
In my stomach, you know, and now it's you know, it's everything's the tension is so much. It's like diminished so much.
You still have some.
Um, Not right now.
And how does the guy look in the picture? Younger man.
Kind of looks funny. I mean,
This is a ferocious
face, but
guy.
still kind of, you know, it looks like maybe it looks like he's laughing.
And this is the same picture he already looked at.
Yeah, it's exactly. It's just it's in the same place, and he's looking with both eyes. This is photobiomodulation for the positive
I
hemisphere.
love writing, but I feel like you know, I still feel like there's a part of me that's afraid or hesitant, but I'm not like. It's not a sense of. It's not a sense where it's not worth doing.
Well, could you write something now?
Yeah, I feel like I'm a little more inspired to write, or I don't feel like I'm impeded by automatic assumption that it's going to be bad. So yeah, I would say so. Yeah, I feel very different now.
That's like flipping a switch.
Yeah. Now it
Yeah,
takes,
right.
again, about 2.5 minutes.
Mm-hmm.
Whereas the envelope, for some reason, works
It's
immediately.
very different. Just generally, I feel like that. You know, I walked in here, it was a gray day, and now it's not so gray anymore. That's the best way I could describe it. So, like the lenses are a little more, the tint is a little lighter.
There are opportunities for you.
Yeah,
If you can succeed.
yes, exactly.
Yeah, that everything isn't going to fail.
Right. You know, it's not everything's gonna go down in flames.
Sure. Okay. I think.
Wow. That's wow. That's
Okay. What I do with this is, see, if I tell him, you're safe now, and you can go ahead and write, and so it doesn't mean anything, and it would be useless. But what I'm doing is creating an experience where he can feel his power, he can feel that he's safer. And that's very compelling. It's sort of like Groucho Marx once said, what are you going to believe? What you see with your lying eyes or what I tell you? And
Mm-hmm.
And so it explains to the patient what his problem is. And what his trauma is. And also, usually the trauma is hidden. In other words, there are patients of mine who've been brutally traumatized, Vietnam vet or a lot of childhood trauma. But probably the majority of people are traumatized in a way that they don't understand as a trauma. In other words, one patient had a very intellectual family, and they always had debates at the dinner table, and the result was always that my patient had the better responses, but the other guy won the debate. He was an older brother, and this caused lifelong suffering. So it doesn't look like a trauma. It looks like it's a very healthy family, and they're doing this constructive thing. But it turned out that actually it was traumatizing to the patient, and so part of this work is to discover the traumas, and then you can bring them out or bring out the mature side where the traumas don't exist much on that side. And so with drug abuse, what I found was that patients would come in with very strong cravings. I give them a unilateral treatment, and the cravings would go away. I would look better. They would feel better about themselves, and they wouldn't. They would have no desire to use. One patient came in. He had an overwhelming urge to gamble, and I said, "Well, I have a casino in the back. But unfortunately, there's a cover charge. So we had an auction, and we got up to $2,000 that he was willing to pay to go to my imaginary casino, and he knew, it was imaginary, but it was we both got into it, and then I treated him, and he wouldn't pay me anything. I said, I'm going to pay my rent. So we decided to test it with drug addicts who I didn't know. So this is a test of people from Craigslist who the criteria was that they had to have cravings. They didn't have to be using, but they had to have 4 out of 10 cravings on the telephone, and it's very hard to study psychotherapy, and there's so many variables, and so we just studied putting the light or a sham, and a sham is the same device with a piece of foil over the light, and the patients can't tell from the device which it is. They can tell by how they feel, and actually in this studies I'm going to describe, the patients all thought they got the actual treatment, and they didn't. It's a really good sham treatment. And but so the patients come in from Craigslist. I don't know them. We're very friendly. We want them to come back, and we're pleasant, and so there is that, and they all came back and they got paid, so it was I think about $30 a session, and which was a lot of money for them, and so we only had one dropout, and so I did a portion of the study from a startup company called Mindlight that I have, and the other group was at McLean Hospital.
And this is your, I'm sorry, this is your most recent study that was just published.
Well,
just this year, right?
That's right. Yeah, the earlier study, because I didn't know if we'd get the grant, I funded myself and did it myself. I had 17 people come in from Craigslist, and so let me see if I have this study here. So this is the first study that we did, and so this was a within subject trial. So there were 17 people who came in. I think we had about 3 dropouts, and the first week that they came in, they got either a sham or an active treatment. And I treated the negative first and then the positive, because I wanted to see if there was a difference between the positive and negative hemisphere. But we treated the positive hemisphere second. So I may have reduced the results by treating the negative hemisphere. I don't know that. But I wanted to get that other thing in. So this was the first study that we did. And so the first week they got sham or active, and the second week they got the opposite treatment, and the third week they got a follow-up. And we measured cravings, and we looked at use. We didn't have enough data to get a good use analysis, and that wasn't a requirement for coming into the study. And we also measured depression. And so what we found was that there was a decrease in cravings at week 3. In the group that got the active treatment, they had a 55% decrease versus an 18% decrease in the sham group. And that was statistically significant with a healthy effect size of 0.73. 0.8 is considered a high effect size. And effect size is sort of the power of the effect. So if you give a Prozac, you have to wait around and 3 weeks, and you look at tea leaves and you try and figure out whether it's working or not. So that has a low effect size. So you need 3,000 people to see if it works. So that wasn't me. The computer decided I ought to change slides. So this is the Hamilton Depression scores. So they came in at 15 and went down to 9, which is quite nice. Now, this is a week after the treatment. So right after the treatment, we didn't see a difference, a significant difference between the active and sham. But a week later, there was that difference. So that's interesting. That it took it wasn't like in my office where we got the immediate results, and the patients didn't. They found it pleasant, but they didn't have these amazing responses. I don't know why. It might be a patient selection, but they did have a week later a highly significant decrease in depression, which is of course important.
And this was just after the 1 4-minute session of active light treatment.
That's right. Yeah, but it's a week later. You can't do a Hamilton immediately after anyway. It's just too complicated. This is a study showing that the active treatment was much better than the to the positive hemisphere was much better than to the negative hemisphere. It was significant. When the light was off, there was no difference. So it does indicate that there's a positive negative hemisphere. So we couldn't look at that a week later. And then, so this was the second study, which was funded by a small business innovation a research grant from the National Institute of Drug Abuse and NIH. And so in this study, we recruited, actually it turned out to be 39 studies, 39 patients. And what we found, so this is all 39 in this graph here. This is from the paper. So people either got an active treatment or they got a sham treatment, and they came in twice a week, and they came in for 4 weeks. So this is the treatment period. This is the follow-up. And you'll see that this is the active group, and this is the decrease in cravings from the baseline. So it's a 10-point scale. And so there's a 5-point decrease in the 10-point scale. So they didn't come in at 10, they came in at say 7, and they go down to 2. So it's really a difference between whether you're going to use or not. If your craving is 2, you're not going to use. If it's 7, you're going to use. So this is these are clinically significant results, in my opinion.
Well, especially since we have such a huge issue with opioid abuse and overuse and overdose deaths. I mean, they were saying 90,000 plus deaths related to opioids just in 2020 alone, and this is a major problem. And there's not a lot of really good treatments to help control cravings.
And again, this is just a 4-minute light treatment. That's what this picture is here. Okay, there's no other treatment but photomodulation and pleasantness. We were pleasant, but we were pleasant in the sham group, and there was a placebo response. went down 1.5 points at the follow-up. Now the effect size here and here at the week after the last treatment, and again we saw that a week later we got better results than immediately. I don't know why that is, but the difference between here and here and here and here is 1.5. The effect size is 1.5. A high effect size is 8, is 0.8 rather. So this is twice high. And it's the p-value is off the chart. It's all zeros. So again, all we did was, so I think we could, go out into the community with a light and treat people and get good results that lasted 3 weeks. After the treatment, and we weren't able to do a long-term follow-up. We just didn't have the manpower for it.
Yeah, that's hard. Yeah.
Just some other things here. So in the whole active treatment group, there was a 70% decrease in cravings. In the sham group, there was about a 30% decrease. So there was a healthy placebo effect, but it was half of the treatment effect.
So the treatment was significantly improved over sham, and that shows, I think, too, that you had a good sham. It's a really pretty clever, just doing everything the exact same, just covering the light with foil. That's really simple, but highly effective.
Yeah, and everybody, except there were about 2 patients who did really poorly, and they thought they got the sham. Just by how they did, but most people thought they got the active treatment when they in fact got the sham, and the active treatment people thought they got the active treatment, and this just shows the group comparison, and then the results. Mindlight is the company, and we got highly significant results, and McLean got very similar results. We both got down to about -5. Actually, it looks like McLean did slightly better, although their sham group did better at McLean for some reason. And then people on buprenorphine did well with the treatment. So if somebody's on buprenorphine with the sham treatment, they didn't improve further than what the buprenorphine did. But the people who were on buprenorphine with the active treatment had went down to 4. So it wasn't quite as good as the looks like, I think this group, I think, actually went down past 5 to about 6. So that's, again, it's a 10-point scale. And if you go down 6 points, again, if you come in at a 7 and you go down to a 1, that's remarkable.
Yes.
In my opinion.
Yes.
So I could see this as an add-on to buprenorphine here, or a standalone treatment.
Mm-hmm.
And then this is drug use, and at McLean they got a much better decrease in drug use, and I think the reason is they had more people who were using drugs than we had at Mindlight, and drug use was not a requirement, but it turns out that we got significant results with drug use. So this is decrease in drug use over the course of the treatment. And so these are days of use. And in the sham group, there tended to be increases. And this is the same thing with the the look back, follow back method. So this is the days times the amount of use. And you see really a healthy decrease in use. And again, it's a subpopulation because most of the people weren't using, but it was out of the 39, I think about 14 or so were using, or came in using, and decreased. And this is days of, so the treated group had almost 100 days less use than at baseline, whereas the sham group had 9 days less than baseline. So there was a healthy improvement in use as well as so these are opiate screens. What we found was that the patients often had negative urines when they reported that they had used. And I think it's because there's a lot of fentanyl out there, and that didn't show up in the urine tests used. So the findings are based on dual brain psychology, and they reinforce the dual brain psychology premises, which are that there's a different personality in each hemisphere related to childhood trauma. And they show that unilateral transcranial photobiomodulation dramatically reduces opioid cravings and use.
And it's safe. And it doesn't conflict with other medications.
Safe. Yeah, we had absolutely no side effects. We didn't have a headache or an ache or a pain. We had no complaints. And I don't have any in my practice. And it's known to be safe. It's not just my finding, but and then there was concern that, well, what if you put it on the wrong hemisphere? You know, you make a monster, and no, you don't. You'll bring the person to his regressed state, but he's been living in that most of his life, and so it's not a great risk.
So, you know, this is a big deal, really, if you think about the amount of problems we have, at least here in the U.S., with opioid use and cravings and abuse and like we mentioned before, overdoses. So you'd think that a really significant study like this, it shows really good effects. It's completely safe. That is, really not. It's convenient. I mean, it's a few minutes of a treatment.
Yeah, and it's painless. It's pleasant. You know, people feel better with it. There really isn't a negative here that I can see.
You'd think this would be just everywhere, like that everybody'd be on board and doing it, right? I mean, that's what it seems like to me.
Right. Now, we're trying to get it through the FDA, and we have to do another study. We have a grant application in. It's another SBIR grant. It's a larger grant. And if we complete that, I think we'll have a good shot at getting FDA approval. So we don't have FDA approval yet. And so we haven't gone to a commercialization phase. And we do have a patent on the unilateral treatment. And we have another we have some other patents pending, and so we're trying to commercialize it, but we would have tried to offer it to the city of Boston, and nobody's called me back. I've made at least 10 calls to drug clinics and halfway houses and stuff, and maybe it's too weird or something.
Well, if you're not familiar with photobiomodulation, the idea of shining a light onto the brain, just it sounds like it's crazy. It sounds like it's not going to
sounds
do anything.
dangerous. Yeah.
Yeah.
And maybe I'll say a few words too about the mechanism.
Yes.
So we know a lot about chromophores and ATP and cytochrome C and mitochondria. This probably isn't working on that basis. It does increase blood flow, but that probably is a secondary phenomenon. I don't think it's the primary phenomenon. My guess is that it has to do with changing your mind. And for that, I think we need to be thinking about quantum physics. And so I've written about brain information and subjective experience. And so what we're doing is we're altering subjective experience, and that comes out of different brain information. So I'm sure that the different hemispheres have different brain information. But what we're doing is we're changing the subjective experience that's associated with that brain information. And so I think we get into quantum field theory and some stuff that I'm not really qualified to speak upon.
Well, of course, me either, but this is fascinating stuff. And I think, you have to have seen, I mean, you already mentioned it, but you have to have seen your field change so much over the last, 20, 30 years. I mean, thinking about where we're going to learn, what we're going to find out in the next 10 even, has to be really exciting. So it's pretty neat to see. I think researchers like yourself that are willing to go out on a limb and say, I know this seems weird, but what if we put these concepts together, and seeing neat results like this is really encouraging.
It also speaks to neuroscience in that I don't think it's a small area of the brain that consciousness is related to. And I don't think that, I think circuits are involved, but they're not the key thing. In other words, we have to get back to minds, and psychiatry has lost its mind. We've gotten our drugs in place of it. And the drugs are not effective. You can get half normal with drugs if you're lucky, if you don't get worse.
Wow. Yeah. Well, Doc, I appreciate your time today. And if you're listening and you want to find out more about the two recent studies that Dr. Schiffer and his team have published, you can find those full studies at the links here in the show notes. And you can also hear my breakdown of those studies by going back to episode 31 and episode 80. We'll put links in the show notes to that too, where I actually run down some of the details directly from the research. But you're hearing from the guy himself today, and he has a publication we already mentioned. It's titled Of Two Minds. The second edition just came out. You can find that on Amazon. There will be a link to that book in the show notes as well. And then if you're learning about photobiomodulation, you want to know more, if you're looking for the right type of device for you and your practice, if you need assistance with safety and certification training or protocols and settings, you can look us up, lasertherapyinstitute.org. We have so many resources available, many of them for free and really targeted to the individual in practice. But Doc, I really, again, appreciate your time and your attention and your efforts in this really important field. Do you have anything else you wanted to share with us before we go today?
Just to say thank you. I've enjoyed speaking with you and the opportunity to share my work.
Well, thank you. And I look forward to seeing more from you in the near future.
Good. Thank you.